Hi, so we're gonna get started soon. I see that there are about 17 attendees here at the webinar. We might just wait for a few more minutes to see if any more people might be interested in joining. So this is my first webinar. I know we've hosted some from ONS in the past. Just to work out some of the technology kinks, would somebody just be willing to put into the chat box or the Q&A box that you can hear me and see me okay? Excellent. Thank you for those responses. So I see our participant list is still growing. Let's wait maybe 1 or 2 more minutes and then we'll get started. Great, so it's 5:03 now. It looks like the attendee list is pretty much stabilized. And so let's get started. So my name is Matthew Cantlon. I am one of the hand, wrist, and elbow surgeons here at Orthopedic and Neurosurgery Specialists, or ONS, out of Greenwich and Stamford. We also have offices over in Harrison, but I really appreciate you all spending your night here with me, and I want to respect your time. So let's get started, and hopefully we make good use of it. Please feel free to enter questions into the box. I will address them at the end, but I'm not going to stop in the middle to do that, but I'm happy to answer any questions you might have regarding this at the end. So, topic of tonight's discussion is called the funny bone, and we're going to be addressing some common conditions around the funny bone or the elbow. So there'll be 5 conditions that I sort of selected to discuss, which are common conditions that I see in the office around the elbow. And that includes tennis elbow, cubital tunnel syndrome, elbow osteoarthritis, various fractures around the elbow, and one particular tendon rupture, which is a distal biceps tendon rupture. So let's get started on probably what's by far and away the most common condition that an orthopedist might see in their office around the elbow, and that's known as tennis elbow. Scientifically, this is called lateral epicondylitis, and I actually like that term much better because tennis elbow is really a misnomer. The tennis part of it, only about 10% of people with tennis elbow actually get the condition from playing tennis. Most of the time, the condition is from other, just regular everyday activities, including gardening or various types of repetitive type uses. And the other reason it's a misnomer is although it hurts at the elbow, it's primarily a problem of the tendon that controls the wrist and the fingers. So this is a tendinosis of the extensor carpi radialis brevis, or ECRB tendon for short. And although that tendon attaches at the elbow, again, as I mentioned, it's primarily a tendon that controls extension of your wrist, or going like this upwards with your wrist. This is a really common condition, so it affects nearly 3% of the population annually, which for any given condition in the orthopedics world, that's a tremendous number. A lot of people on this presentation may have heard of carpal tunnel syndrome, which is a really, really common condition around the wrist, and this is about the same number of people as get carpal tunnel syndrome in any given year. It generally affects people sort of in the middle years of life. and generally between age 35 and 60, but there are certainly exceptions to that. And I see people both younger and older than that who do get this condition. It has a slight predilection for the dominant arm by about 55% dominant arm, 45% non-dominant arm. And there's an equal gender distribution. So this is something that affects men and women fairly equally. If we think about the outer part of the elbow here, where we experience tennis elbow, there's a bony prominence at the very outer part of your elbow, and that's called the lateral epicondyle. That bone itself is not really affected. It's what's attached to that bone that becomes affected. And there are various tendons that attach to that bone, but the culprit is thought to be the extensor carpi radialis brevis, or ECRB tendon. And as I mentioned, this is a tendinosis. So it's not really just a tendinitis, which should imply that it's an inflamed tendon. It's a tendinosis in that it's a somewhat degenerated tendon, which is why this doesn't really happen at age 20 or 22 or 25. There's some amount of degeneration that predisposes to these microscopic tears from overuse. Usually this is a clinical diagnosis and imaging is not required. So oftentimes we don't get x-rays, we don't get MRIs because they're often not needed for this diagnosis. Oftentimes the diagnosis comes from a patient history. Most people say that there was an insidious onset, meaning it just gradually came on. There was no fall or one particular moment in time when they felt a pop, a rip, or a tear. Oftentimes people have difficulty holding even simple items, such as picking up their purse or holding a cup of coffee in the morning or opening a door that requires heavy twisting. There's almost always tenderness on the outer aspect of the elbow, right at the insertion of the ECRB. And the most common finding that we see, and sort of the way to confirm this, is pain with resisted wrist extension and sometimes resisted long finger extension. So what the examiner is doing in this position is the wrist is fully flexed down and they're asking the participant to extend their wrist up, and that would usually recreate the symptoms. The good news about tennis elbow is that it often resolves spontaneously, or meaning without any specific intervention. And 90+% of people, it will be better, but it can often take significant number of months and even up to a year for this to fully resolve. There are a number of different non-surgical options. By far and away, the best is a certain amount of rest and modifying activities that make this hurt. So for instance, if we think about tennis, which about 10% of people who have lateral epicondylitis or tennis elbow, it is from playing tennis, there are various modifications that can be made, such as using a lighter racket, expanding the grip on the racket to being slightly larger, decreasing string tension that decreases the vibration of impact of the ball through the wrist and forearm. So for any given thing that's the cause of the underlying problem, there are ways to modify those and try to still be active. There are various types of braces that can be effective. Probably the single most effective brace would be a wrist brace. And that's because it prevents use and extension of the wrist, which is the main culprit here in causing tennis elbow. Anti-inflammatories have some role, at least on a short-term basis, even though this is not primarily an inflammatory problem, it's a tendinosis. There clearly is some role for anti-inflammatories to bring down some of the surrounding inflammation. Physical therapy can definitely help here, and not only for some of the stretching and dynamic strengthening that can be done, but also for some of the other modalities, such as the massage and the ultrasound and the Graston, to try to bring some healing to that area. When those don't work, there are some slightly more invasive, but not very invasive things that can be done, such as cortisone injections and platelet-rich plasma injections. Neither of them are home runs for treating this, but they certainly are adjuncts to helping out. And especially if, say, 4 or 6 months go by where there's no significant relief with those other options, cortisone and PRP injections certainly enter into the equation more prominently. There certainly is surgery available for this. For most people, we reserve that to pain that's been persistent for greater than a year, and we've tried these other non-operative options. And in general, it's fairly rare that we have to move on to this, and that's because, again, 90+% of people do get better without needing surgery. There are various ways that surgery can be done for this, and all of the studies show that they're essentially equivalent in their long-term outcomes. This can be done through sort of more minimally invasive ways, including arthroscopically, as well as with a percutaneous release. Percutaneous simply means with very, very small incisions through the skin and sort of releasing the tendon. or there can be an open debridement or repair. Really, again, because they're all equivalent, there's really no preferred way to do it, and they all lead to very similar outcomes, which is about 80 to 85% relief of symptoms if you look 3 to 6 months down the road. Let's move on to another very common condition, which is cubital tunnel syndrome. So a lot of people have heard of carpal tunnel syndrome. Carpal tunnel syndrome is a condition where a nerve in the wrist, it runs right in this area known as the median nerve. That nerve gets pinched in that area. It's often related to repetitive wrist use, but its cousin, called cubital tunnel syndrome, is when a different nerve, which is the funny bone nerve, the title of this talk, gets pinched in a different tunnel on the inner part of the elbow, and that tunnel is called the cubital tunnel. It's actually not just one tunnel. There's actually a series of tunnels that make up 7 different points where that nerve has the potential to get pinched on the inner part of the elbow. When that nerve does get pinched, it's known as ulnar neuropathy or ulnar nerve neuropathy. The first signs of any issue with the ulnar nerve are numbness and tingling in the pinky finger and the ring finger. The most common time that would happen is actually waking up in the middle of the night, because oftentimes we'd be flexed up like this with our elbows very, very flexed for long periods of time, and that can put increased pressure on that nerve inside that tunnel. It can progress, though, over time. If that goes on unchecked for long periods of time, it can move on to also cause weakness of the hand. And that's because the ulnar nerve provides sensation to the pinky finger and the ring finger, but also provides power to most of the muscles of the hand. And so as a result, there can be significant weakness of the hand in later stages of this issue. This tends to be worse with elbow flexion, and as I mentioned, the primary time when it actually starts is when we're asleep and we're kind of curled up, our hands are up under the pillow, and we spend a long time in flexion and we're not awake to realize it. The diagnosis of this is often by history and physical examination. One of the things we can do is to try to recreate those symptoms with the elbow flexion test, which is really very simple. It's keeping the elbows in high flexion like this, and sometimes even putting a little bit of pressure on the inner part of the elbow and seeing if it recreates the symptoms over the course of 30 or 45 seconds. The other thing we can do is when the elbow is taken through a range of motion, going from full extension to full flexion, we can see if the nerve is coming out of that groove or out of the tunnel. That's called nerve subluxation, which is where the nerve can slip. That can especially happen in young active males where they have big triceps muscles, and it can actually push the nerve out of the groove. We can also do a more formal and objective sensory exam where we can formally test how well the nerve is providing sensation to the tips of the fingers and how well the muscles of the hand are working. Sometimes when the diagnosis isn't perfectly clear, or if there's a need to actually kind of grade the severity of the issue, we can get what's called an EMG or electromyogram and nerve conduction study test. It's a non-invasive test where we can put electrodes along various points of the nerve on the upper extremity and see how well the nerve is conducting electricity. That does help grade the severity. Also, as I mentioned, if the diagnosis is in question, it's also really helpful. Sometimes we can have a pinched nerve in our neck and we don't have any pain in our neck, but it can lead to radiation of numbness and tingling down the arm. Much like sciatica can have a pinched nerve in the lower back, and it can lead to numbness and tingling that radiates down the leg. And it can be challenging in certain cases to actually differentiate those two, and sometimes a nerve test can really help localize where the problem is. The first line of treatment for cubital tunnel syndrome is attempting to keep the elbow in a straight position. And that's because when the elbow is in flex, such as if we're up on a phone and we're not using any headphones or headsets, or if we're holding a bag or luggage or purse on the top of our shoulder, when the elbow is flexed like that, it puts a lot of pressure on the ulnar nerve. And that pressure is relieved when our elbows are relatively extended. And so avoiding things like that, if we're in a call center, switching to headsets or headphones, if we spend a lot of time on our cell phone, again, switching to Bluetooth headsets can be really helpful, and consciously avoiding high flexion of the elbow. At nighttime, that's harder, and so sometimes at night, we recommend wearing extension splints. It simply prevents your elbow from going into high flexion when you're not conscious and you can't avoid it. If that doesn't work, in a minority of patients, we do move on to surgery. And that's a big jump. There's not a lot we can do for this between non-operative things like wearing a splint and preventing flexion and surgery. Studies really haven't shown any big role for cortisone injections or physical therapy or a lot of these other non-operative interventions. And so really there's a big jump in this particular condition between the non-operative management and the surgical management. But surgery for this is a fairly common procedure that we do, much like in carpal tunnel syndrome, where we relieve pressure on the nerve that's traveling through a tight tunnel. We do an identical thing here, where we relieve pressure on the nerve at those 7 pinch points that I mentioned before. Once we've relieved the pressure in those 7 pinch points, a really important part of the procedure takes place, which is where we move the elbow through a range of motion. Because we've taken the roof off of the tunnel, the nerve can now sometimes slip out of its groove. And about 20% of people, after taking the pressure off the nerve during surgery, we find that the nerve is now slipping in and out of the groove. And then we have to formally move the nerve to a different part of the elbow, just a few centimeters to the front part of the elbow. And that's so that the nerve isn't slipping in and out of the groove, and it's in a happier position on the front part of the elbow. And that's called a transposition procedure. It adds about 20 minutes to the procedure. It adds a little length to the surgery, but a patient wouldn't be happy if they had nerve subluxation and it wasn't addressed at the time of surgery. Let's move on to another condition. So we'll talk about some elbow osteoarthritis. So in the grand scheme of arthritis, this is actually one of the least common joints that becomes arthritic. So common joints that become arthritic are various joints in the hands, the basal joint of the thumb, hips, knees, and even shoulders to some degree. Elbows are relatively uncommon. The most common patients who get elbow arthritis are actually patients with rheumatoid arthritis. And in the last 15, 20, 30 years, as rheumatoid arthritis medicines have gotten better and better, we're actually seeing a lot less elbow osteoarthritis because we're able to prevent it on the rheumatology side of things with various types of medicines. We're still seeing it though, and that's in some patients who have uncontrolled rheumatoid arthritis, but we also see it as a post-traumatic condition and in a laboring condition, meaning laborers who worked all their life with heavy conditions are at much increased risk to getting elbow osteoarthritis. Post-traumatic is when we have some sort of injury around the elbow that predisposes us to developing arthritis. That tends to be a broken bone at some point in our life, whether it was when we were younger and it didn't heal in quite the right position, and over the course of 30 or 40 years, there's some wear and tear inside the elbow that wouldn't normally have been there, and that can lead to elbow osteoarthritis. We usually don't have to do anything invasive for elbow osteoarthritis. Much like arthritis in other parts of the body, we first try to control the symptoms. We don't have a way to reverse time. We don't have a way to necessarily give you a normal joint again. We don't have a way to necessarily halt time either, in that we don't have a way that we know of to stop the progression of arthritis. But we do have some ways to control the symptoms of arthritis. And some of those ways are cortisone injections into the joint, various oral anti-inflammatories. Sometimes the arthritis can actually cause contractures of the elbow where we can't move the elbow nearly as well. And in moderate cases where it's not so severe, we can potentially do an arthroscopic procedure where we remove some bone spurs that have formed that are actually preventing motion and blocking motion. And that can actually improve motion and improve pain. In very rare cases, are we still doing total elbow replacements. Hip and knee replacements have become nearly ubiquitous, especially in this country, because the implants are really, really good. And it gets young, healthy people who have arthritis back to doing things that they enjoy doing. The implants here haven't progressed to the same degree that implants in the hip and knee have progressed. And as a result, we still don't do this procedure all that often. We can really only do an elbow replacement procedure in a low demand patient, and low demand because there's a very high risk that this implant loosens over time. And so as a result, there's a lifting restriction for lifetime of no more than about 5 to 7 pounds in this arm. So if we did a total elbow replacement in a right elbow, that patient would never be able to lift more than about 5 pounds in their right arm again for the rest of their life. And that's because there's such a high rate of loosening. If we lift too much, that wiggle, 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 and that toggle of the implant will eventually loosen over time. It's also just generally a high complication rate, and so it's not great for young, healthy people. There's high risk of infection in this procedure. There's a risk of triceps insufficiency, and that's because of the approach to actually putting in the implant, that the triceps muscle just sometimes doesn't work nearly as well afterwards. Let's talk about some common elbow fractures around the elbow. So by far and away, the most common fracture around the elbow is a fracture called the radial head. And if I put my cursor on it, hopefully you can see that. This is the radial head right here. We can see that this white line would normally be intact, and we can see that there's a break that comes right across in through here. Although this is a fracture in the elbow, this most commonly occurs from a fall onto an outstretched palm. And when we fall on an outstretched palm and our body weight comes down on our hand, sometimes it knocks the two bones together. So the radius bone hits into the humerus bone, and that causes a fracture of the radial head or radial neck. These are really common injuries around the elbow. Actually, 1/3 of all fractures around the elbow are radial head or radial neck fractures. And of all fractures throughout the entire body, radial head and radial neck fractures make up nearly 5% of all those fractures. So it's a really common injury. The good news is the vast majority of these fractures are treated without any surgery. And even better news is these often don't need casts or splints. We actually put a patient into a sling for an injury like this, and we allow early range of motion. There are very few bones in the body that we can do that with, but the radial head is one of them, and that's for a few reasons. One is that we know that early range of motion doesn't significantly shift this piece of bone, and so we don't usually lose the reduction or lose the position of the fracture by allowing early range of motion. The second reason is that elbows tend to get extremely stiff. And so if we immobilize an elbow for 6 weeks until the bone is healed, which isn't necessary here, our elbows really become very stiff, and we'd likely never move our elbow normally again after immobilizing it for that length of time. Occasionally, we do need to do surgery for these, and generally there are a couple different things that can be done. In sort of more minimally displaced ones that simply just need to be put into a better position and held there, we can do what you see the picture on your left, which is an open reduction internal fixation, which means kind of opening things up, pushing things back into place, and then holding them there with some sort of hardware. In this particular picture on your left, there's actually 3 screws that are buried in the bone holding the position of the fracture. In fractures that are in more pieces, so it's thought that if there are 3 or more pieces when it breaks, and that can happen just from the nature of the injury, it's better to actually replace the radial head than actually try to fix it. And so what you see in the picture on the right is called a radial head replacement. It can be made out of various metals. The most common one that we see is titanium, and it has this small stem that goes inside of the bone and actually is a replacement for your old radial head. This is another common fracture around the elbow called an Olecranon fracture. Unlike a radial head fracture that usually happens from a fall onto an outstretched palm, this usually happens from a fall directly onto the point of the elbow. In this particular injury, you can see the fracture line coming right where my cursor is, right up and through here. And the reason why this is significant is that the cup of the joint should normally be intact. So we would see this white line be intact, but we can see right here the white line ends and picks up again right here. So there is a gap in the joint, meaning the cup that the ball and cup normally glide smoothly on has a step off, and that will cause some grinding if it isn't fixed. The other reason is that simply putting an injury like this into a cast does 2 things. One is there's a high rate that this goes on to further displace, and that's because there's the pull of an important muscle in the back part of the elbow called the triceps muscle and triceps tendon that's constantly pulling on this piece, much like a rubber band that's constantly pulling, and even in a cast, you can't offset that force. And the second reason, as I mentioned before, is if you immobilize an elbow for too long, motion never comes back. And so almost everybody who has an olecranon fracture actually needs to have surgery for it. And there's various ways to fix it. I've elected to just show a simple way to fix it, which is called a tension band. It requires 2 sort of smooth wires and then a bendable wire. And it holds all these pieces in place and allows early range of motion. After a surgery like this, oftentimes a patient would be immobilized for maybe a week after the surgery just to allow the soft tissues to calm down, and then we'd begin some physical therapy at that point. So instead of being 6 weeks in a cast and the risk of things displacing, the bone is in a perfect position and you're able to start moving right away and start to regain motion. One other common fracture around the elbow is called a distal humerus fracture. So humerus is the bone that travels from the shoulder down towards the elbow. The word distal simply means further from the center of the body. So various parts of the humerus bone can break. It can break up at the part by your shoulder, and that's called a proximal humerus fracture, or it can break at the part down by your elbow. That's called a distal humerus fracture. Now, unlike the radial head or the olecranon, where they usually happen in very predictable ways, distal humerus fractures can happen in a lot of different ways. It can happen from a direct hit to the bone. It can happen from a twisting incident where somebody would grab a pole and then get flung around the pole. That actually, I've seen a patient recently who had a similar injury to that. Or it can actually happen from a fall onto an outstretched hand, just like the radial head fractures can happen. Much like olecranon fractures, these almost always require surgery as well. And that's for the same reasons as the olecranon. These tend to move and shift over time, even in a well-placed cast. And again, the downside of immobilizing for so long, even if it were to stay, is that the elbow would become extraordinarily stiff. So in order to fix these properly, it does require quite a bit of hardware. And this is a very common way that we fix this, which is 2 plates and 2 sets of screws on the bone, one on the inside part of the humerus and one on the outside part of the humerus. Because there are such strong muscle forces that go across the elbow, it requires really strong hardware to allow motion of the elbow without the fracture moving or shifting. It takes about 6 to 12 weeks for the fracture to heal, and at that point, the hardware really isn't doing much anymore. But until the fracture heals, if we'd like to allow motion, we need something really strong holding things in place. And let's move on to our condition, which is called biceps rupture. So unlike lateral epicondylitis or tennis elbow, which was an extremely common condition, this is a relatively uncommon condition. This has about 1.2 per 100,000 person years, and we compare that to lateral epicondylitis or tennis elbow, which is about 400 per 100,000 person years. So this is almost 400 times less common than tennis elbow, but that's a good thing because this is a much more devastating injury than tennis elbow would be. This almost always happens in men over the age of 40. It usually happens in the dominant elbow, and there's a significantly increased risk that this happens in people who smoke tobacco than people who don't smoke tobacco. If we look, the biceps muscle is actually made up of 2 muscles that are between your shoulder and your elbow. This traverses 2 joints, so unlike a lot of muscles that really only traverse 1 joint, the biceps muscle traverses 2 joints. So it attaches way up above your shoulder, and it also attaches way down in your elbow. It's actually made up, as I mentioned, of 2 muscles and therefore 2 tendons. One's called the long head of the biceps and one's called the short head of the biceps. Interestingly, when people say, show me your muscle, we think that's your biceps. And although that is the muscle you're seeing, the primary muscle that provides flexion of your elbow or coming up like this is actually a muscle underneath the biceps called the brachialis. And the primary role of the biceps muscle is actually to supinate your forearm or go palm up. So from palm down to palm up. The primary muscle that does that is your biceps muscle. As we see, the biceps muscle at the elbow inserts into this bump on the radius. That's right here where my cursor is. And it inserts onto this bump called the radial tuberosity. And when the biceps pulls, it actually rotates the radius, which is what supinates our forearm. And we can kind of see that in the cadaver picture over here. So when we pull on this tendon, the radius actually rotates instead of actually flexing up. Usually this is a diagnosis that can be made both on clinical examination as well as a history. Patients often know that they felt a pop, and that's the pop of the tendon coming off the bone. Sometimes there's actually some antecedent pain, meaning there was some discomfort in this area that preceded the pop. And that really what that was is likely that the tendon was either partially torn or at significant risk of tearing because it was degenerative. And then there was some maneuver or some heavy lift that caused the tendon to actually pop, and patients then experience a popping sensation or feeling. It often leads to what's called a Popeye deformity, which is that the muscle now, because it retracts, looks really big in the arm. It leads to weak supination. You lose about 40% of your supination strength if the biceps muscle and tendon is not intact. and it leads to a loss of about 10 to 20% of elbow flexion if the biceps tendon is not intact. We can often do a maneuver in the examination called a hook test. You can see that's demonstrated both by the finger as well as in the bottom picture by a hanger. If the biceps tendon is intact, you can feel it either with a finger, and it's usually intact enough that you could even hang a hanger and a coat off of it. But if the biceps tendon is ruptured, you wouldn't be able to do either of these maneuvers. We often do get an MRI. It's one, to confirm the fact that there is a tear, and two, to see if there's any significant retraction of the tear. Because this is usually a surgical diagnosis or a surgical problem, we often like to have an MRI to see if there is any retraction, which might help for surgical planning if a different incision or a second incision has to be made to actually pull the tendon back down. And what you can see is from this drawing on the right-hand side, oftentimes what happens is the biceps tendon pulls off and then actually curls up. And you can see that on this MRI here, where this black structure is the end of the tendon where it's come around here, and it's actually curled back up on itself because it's no longer stretched out. There are a lot of different ways to fix this, and a lot of different ways have been described. A common way that was done maybe 20 to 30 years ago is something called a bone tunnel, where the tendon is retrieved, a hole is made in the bone, 2 incisions are made, one in the front part of the elbow, one in the back part of the elbow, and then the tendon is pulled through that tunnel and sutured in place. At a similar time frame, this technique came up where there are suture anchors, which are quite literally anchors that go into the bone. They're made to go into human bone, just like an anchor might go into a wall. And the anchor has a suture attached to it. And once that anchor goes in the bone, it's solidly in the bone, and then that suture can tie the tendon down to the bone. A third technique is you retrieve the tendon, you put it into a socket that's drilled into the bone, and then you put in an interference screw. What that means is you simply fill that socket with both the tendon and a large screw so that it's sort of held in by friction until it has a chance to fully heal into place. And then there's the most modern way to do this, which is repairing it with what's called a cortical button, which is retrieving the tendon, drilling a socket into the bone, tying suture through the tendon, and then actually tying that suture through a button that's on the other side of the bone, and that's that button right there. It's usually a metallic button, and that button usually stays in for the rest of a patient's life, doesn't set off any airport issues, doesn't cause any problems, and it's actually been shown to be the strongest in terms of its fixation strength. So you can see that each of these has been tested in various settings, mostly in cadaver labs, and the strongest fixation is in the bottom right, which is sort of why it's now the modern way to fix this. So these are the loads that the initial repair can sustain. So in the top left, it can sustain 310 newtons of force initially before it would re-rupture, whereas in the bottom right, we can sustain a 440 newton load of force without it actually re-rupturing. And because it's such a strong repair, unlike what used to happen where you'd have to be splinted for a long period of time, we actually can let patients start moving their elbow almost immediately. So I let patients start moving about 5 to 7 days later after some of the soft tissues calm down. So thank you all for your attention. I wanted to leave time for some questions, and I'll take a look at some of those at this point. All right, so one question that's on here, that's a great question. It says, can olecranon bursitis lead to cubital tunnel syndrome due to increased pressure on the ulnar nerve? So to address that, let's talk about what olecranon bursitis is. So olecranon bursitis is when there's some inflammation in the back part of the elbow, or right over the point of the elbow. That usually happens from a direct fall on the elbow, but can happen for various other reasons. It can happen completely out of the blue. It can happen from overuse. And as I mentioned, it can happen from some trauma on the back of the elbow. We have normal bursal sacs throughout our body. They live in our shoulder, in our elbow, in our wrist, in our knee, in our hip. And those normal bursal sacs can become inflamed, and that's when it becomes called a bursitis. Olecranon bursitis usually isn't very subtle. Oftentimes people notice a big ball, almost like a balloon, on the backside of their elbow. The good news is that it's usually not a cause for major concern. It can come in two varieties. There can be a non-infected kind, which is the vast majority, and there can be an infected kind, which is the minority. In terms of can it lead to cubital tunnel? It's unusual that it could. That's not normal. Usually the bursal sac does not expand and actually put pressure on the ulnar nerve. I suppose that it could if it got big enough, but it usually doesn't ever get to that point, as patients tend to present earlier on, and either we do something about the olecranon bursitis before it causes any ulnar nerve pressure. But certainly if there's a big enough olecranon bursa, then it could put some pressure on the cubital tunnel and on the ulnar nerve. So one question that I'll address here, so it asks for tennis elbow, which type of brace do you prefer and why? So there are literally 1,000 different braces. If you were to Google for tennis elbow braces, what might come up? There are really only two that I strongly recommend. First off, I would avoid any braces that specifically cover your elbow. Although, as I mentioned, this has elbow in its name, this is primarily a problem with wrist and finger motion and gripping. And so the brace that I personally prefer for tennis elbow is a wrist brace. And that's because it prevents wrist extension and wrist flexion, which is really the culprit in tennis elbow. So it's the wrist motion and the gripping that's the underlying cause. And so by far and away, the best brace for tennis elbow would be a wrist brace. Oftentimes people say, well, how do I wear a wrist brace all day long? I usually say don't wear a wrist brace all day long, but try to wear it at least for bedtime. And that's because when we're asleep, we're moving our wrists around without being conscious. And then secondly, wear it as much as reasonable during the day, and especially during things when you think you might be doing repetitive activity over and over. The only other brace that I would recommend for tennis elbow is called a tennis elbow strap or a show part strap. It's a strap you've probably seen people wearing. It goes across the forearm like this. The reason why it works, so if you think of a guitar and a guitar fretboard, if you pluck a string on a guitar, the entire string will vibrate. But if you put your finger lower down on the fretboard and pluck that guitar, only the portion of the string will vibrate from where you plucked it to where your finger is on the fretboard. And so similarly, if you were to put some pressure on the tendon before it inserts in your elbow, the idea is now when you use that tendon, you're unloading where the tendon actually inserts. And so theoretically, it makes sense to me. I find that some people really like it and some people don't find so much benefit from it. But those are the two braces I would recommend. One patient asked a specific question that's a little hard to address without any more information. The question is about some intermittent elbow discomfort that hurts when they do biceps curls or lifting groceries. It's hard to know exactly what that is. I think it's probably worth a quick examination in the office to fully address something like that. It could be a biceps tendonitis. It could be a lateral epicondylitis. It's usually going to be a tendonitis problem, and then it just comes down to which tendon it is that's involved. It certainly could be a biceps tendonitis if it's only with lifting and using the elbow and not with using the wrist. Another good question. Somebody asked if with active tennis elbow, are strengthening exercises helpful, even though I'm still experiencing quite a bit of pain, or is it worth letting the pain subside and then starting to exercise it? So good question. In general, if we're still having quite a bit of discomfort, we want to use things less. So overuse injuries such as lateral epicondylitis or tennis elbow, generally we want to use them less first. And as they start to feel better, we can start doing some more with them. So it's really hard to get tennis elbow better while trying to actively use it and actively strengthen it. It's really hard to get it better if we're still playing tennis. It's really hard to get it better if we're actively trying to strengthen it. So I usually recommend letting things settle down first, doing some non-operative things that I mentioned, resting it, modifying activities, bracing, oral anti-inflammatories, seeing if we can get it to calm down, and then starting strengthening. If we are strengthening, you only want to strengthen in one particular way. And it's something called eccentric strengthening, And it really requires probably seeing a therapist to actually learn how to do it correctly. There's a lot of misinformation on YouTube if you were to Google how to do that stretch. And it requires probably 10 minutes to really figure it out and learn how to do it properly. And so if we're going to strengthen, again, eccentric strengthening is really the only way that you would want to do it for tennis elbow. This is a question that's a little bit out of my realm, but I'll address it as best I can. The question is, my 46-year-old daughter has had severe elbow pain for months, has had every available test. The latest diagnosis is psoriatic arthritis. Do you have any thoughts? She's done yoga. So psoriatic arthritis is a type of autoimmune arthritis. It's like rheumatoid arthritis, but not exactly the same. It has a different sort of clinical picture in what organs it affects and which joints it affects. Generally, somebody with psoriatic arthritis would be managed by a rheumatologist. And there are various types of medicines, if they have a formal diagnosis of psoriatic arthritis, that they would want to attempt. I'll say there's a famous professional golfer, his name is Phil Mickelson. He has known psoriatic arthritis. And there are medicines that still allow him to play at an extremely high level as he's still competitive in PGA Tour and the Senior PGA Tour. And so there are definitely medicines out there that can help psoriatic arthritis. That tends to not ever get into the orthopedic realm. I tend to not see a lot of people with that because it's just mostly managed by rheumatologists and not orthopedists. Somebody asked me to clarify for tennis elbow, why did I say that we should avoid covering the elbow? The only reason why we should avoid covering the elbow is that braces that cover the elbow just tend to not work. So as I mentioned, tennis elbow is a problem with the extensor tendons of the wrist and fingers. And so covering the elbow does not affect the motion of the wrist and fingers at all. And so as a result, just tends to not be as effective. Now, certainly putting a brace on your elbow sometimes makes it feel good. And if that makes it feel good because there's some compression on the elbow and just feels like it's giving it some compression, then feel free to do so. That there's no good scientific reason why putting an elbow brace on your elbow should help minimize the symptoms of tennis elbow. Just looking to see if there are any other questions. And I'll give it another minute if anyone has anything else to type in. Excellent. Well, thank you all so much for your time. I hopefully respected your time here, and we hopefully started on time and went through some common conditions in a timely fashion, covered some questions, and as always, happy to see any specific people as we, if you have any specific questions, would be happy to see you in the office for consultation or anything else. So take care, be safe in this crazy environment, and hopefully you can stay out of our office with some of these prevention techniques here. Take care. Bye-bye.